pedigree, long QT, neurological feature but no deafness. And this is also consanguinity presents. And we didn't get any change in the ECG findings. This is a normal ECG QT interval corrected. So what will the possible diagnosis you think? And they have the symptomatics. All of the neurological features symptomatics. So this is called now autosomal recessive Romanov-Bard syndromes. Why it autosomal recessive? Because we got the homozygous mutation in that case. So we published that paper so one more left. So this is another category. You can see this is the family he is 21-year-old and there are multiple sudden death in the families, and this was the same family with later follow-up. So QT interval correct is 430. You can see this one. And sudden death in the families. What will the clinical diagnosis in the proband? In that case, sudden death between 10 to 13 years of age. And their deafness and long QT both. So if we analyze the pedigree, it is JLNS carriers because he don't have the symptoms. So if we analyze this long QT phenotype on the basis of clinical feature, we can divide in the 4 or 5 phenotypes. JLNS carriers, JLNS affected, Romanov-Bard syndromes, autosomal recessive Romanov-Bard syndrome affected, autosomal recessive Romanov-Bard carriers. So what the exact genotype actually well defined by the phenotypes, which you can easily get by pedigree and the family analysis. So you can make minimum this impression without the molecular testings. For molecular testing, you need to confirm this. In this only the autosomal dominant is Romanov-Bard syndromes, which is QT prognosis associated with the syncope with death. When there is no deafness, in an autosomal recessive form of this KCN1, we call autosomal recessive Romanov-Bard syndrome. We published that one. 5 family with autosomal recessive Romanov-Bard syndromes. So not all cases present later of the age after 10. Few are, the mutation is very lethal, means it is in the intercellular portion is one of the mutation is, this is not our study case. This I just to put for understanding, means few case mutation are too lethal, it is present in intrauterine life. And the child, these families come actually, they describe the recurrent spontaneous abortions. The 2 child died intrauterine life because of cardiac arrhythmias. And they identified antenatally by ultrasounds, the abnormal heart rates, echoes, and antenatal echoes, and this is very lethal because this will lead to a very sensitized channels, KCNQ1. So KCNQ1 not only lead to the long QTs and short QTs, also lead to atrial fibrillation, familial short QT syndrome too. And if we go to the OMIM, the allelic variation is, they reported too much variation, which is fewer, still we don't know the exact pathophysiology is, create some modifier effect to the other mutations. At any variation, we still need to develop a data of all phenotypes to better studies. And the recent our knowledge, we are doing to develop what is the long range gene effect of the regulating portion of the KCN1 can affect the phenotype interfamilial. So why we need to need for molecular pathology to studies, even we can make the clinical diagnosis. To confirm the clinical diagnosis, because dysmorphic syndromes or metabolic disorder, all known syndromes, we can make clinical few of the very well established clinical criteria or scoring systems. But many of them don't have any scoring system, we need to confirm with the molecular studies. Research and for undiagnosed familial or hereditary disorders, new syndromes, make data for genotype-phenotype correlation, severity of disease, allelic heterogeneities, like KCN1 related long QT, we already discussed too much genetic heterogeneities lead to also, long QT is genetically heterogeneous, and KCN1 related disorders allelic heterogeneous, means within allele there are different phenotypes, and the same long QT phenotype lead by the different genes mutation. It's called genetic heterogeneous. And it happens with other genetic disorders. To know the molecular mechanism of pathology, means pathway recognitions, so we know better interactions, we can do the drug therapies which is maybe non-genetic to affect the disease course. Overall management of genetic disorders, online update guideline of management in gene review you need to follow to make the update diagnosis management protocols. How it is helpful to the patients, molecular confirming the disease, so we can tell the families what to happen the next. We can make the surveillance guidelines. We can make the high risk factors not to do it, you can do it. Antenatal diagnosis for the family, so they can better preventive measures. Judge the phenotype even a fetal life or pre-symptomatic stage. Alter the disease course by pathway modification or understanding the molecular mechanism of the pathology. Now beta blocker for long QT is one of the example. Losartan for Marfan syndromes, folic acid for neural 2 defects, many drugs metabolic disorder at a stage of development now. Greater help in the overall genetic counseling. So what is happening? This is I didn't include the more advanced in the cardiac genetic disorder. We at a stage we can transform the fibroblast to pluripotent cells to make convert to the cardiomyocytes and do the understanding the pathways and gene influence interaction between gene to genes. So it is a future. Maybe we do the gene already 1 or 2 unpublished data is there. And research trial. The gene therapy may alter the expression of the channelopathies and maybe alter the disease course. No need for ablation or a long-term therapy. Studies for molecular genetic testing is cytogenetic studies, which include the chromosome studies, phase, fluorescence to hybridization and microarray. Molecular sequencing studies mostly PCR based, and advancing PCR gene suspecting for well-defined syndromes is called target molecular testing, which you well-define the etiology and you will test directly. Like if you did the electrophysiological marker very strongly on that cases, you will directly go through to particular gene. If you don't get the marker for electrophysiological and the picture is not clear, you will go to the more advanced like linkage study, which is the old one, but nowadays is replaced by the whole exome sequencing or genomic sequencing because linkage study is more laborious and need to lot of efforts. But always in a low resource area, I will advise you, if the patient you think it may lose, store the blood for DNA banking. Thank you. This is the resources of the Mendelian disorders, which is included in the genetic research studies for NCBI for OMIM, genetic home reference, gene review, PubMed. This is the main sites. We update ourselves. And there are different sites for different subcategory of medical genetics, means skeletal dysplasia, dermatologicals, etc. Thank you. If any questions or any feedback, if you have the family like this, you can email me, or for the counseling of that family, I will be happy. Thank you. Any question?
Excellent.